So this is the second panel, and what you can see from this is we've gone from international comparisons, dealing with jurisdictions of both private and public funding for health services delivery. And now we're looking at the Canadian context. And this panel, the topic of that is politics and economics of private finance in Medicare in Canada. This is an opportunity for us to think about some of the challenges, the economic challenges, some of the other political issues that might result from the decision from Canby surgeries. But what I've heard so far and what I've often thought is that we have this immediate decision in front of us as it relates to the Superior Court decision in BC. But I worry sometimes that we'll just have that decision, and if it's favorable, then we can go back to sleep. And I would think that that would be a huge loss. So I would like us all to think about how we would like to change our healthcare system anyways, and use this as an opportunity. So by way of introductions then, I'm Jeff Turnbull. I'm the medical director of Inner City Health, so I look after all of those patients that you've just seen in the last day or so in the market who are homeless. I still lead the equity work for Health Quality Ontario, but have changed a lot of my jobs to address the immediate pressing challenges that we face in homelessness and the opioid crisis. More importantly, however, we have three very distinguished guests. I'm going to introduce them very, very briefly. Their bios are much more extensive than what I'm going to do credit to, but their bios are also in the materials that you've been provided, and their abstracts as well. So our first speaker will be Professor Jerry Hurley. Jerry is the Dean of the Faculty of Social Sciences and a professor of the Department of Economics at McMaster University. He has a special research interest in the economics of health and healthcare systems. The second speaker beside him is Professor Mark Stabile. Mark is the Stone-chaired professor in wealth inequality and a professor of economics at INSEAD in France. And he has a special interest in inequity, poverty, child health, healthcare financing, and tax policy. And then our last speaker, Ake Blomqvist. Ake is currently a health policy scholar at the C.D. Howe Institute and an adjunct professor, research professor at Carleton University. And his area of research involves economics of developing countries and the economics of healthcare. So I think you're in for a very good description of some of the economic and some of the political issues that we face in a two-tiered system. So I'll stop and introduce our first speaker, Jerry.
Thanks very much. I'm very pleased to be here today. And so I was asked to speak to issues around the economics of parallel systems of finance, and then into some of the regulatory issues that arise from those issues. These are, of course, both very big areas, and so I'll try and make a few points, obviously, in my short time, and then maybe in questions and answer we can get into particular issues that are of particular interest to you. Again, my focus is on systems of parallel private finance. I'm not going to speak at all really to the complementary insurance system that we currently have in Canada. And I hope throughout my remarks to emphasize where I think there's things that the evidence and our knowledge is actually pretty clear, and where things might be more contestable. Let me start with a few basic points around markets for private insurance, parallel private insurance. And really the first point is a very basic point that I think most in the room would be aware of, but I think it's worth emphasizing. And it's one that I think no one would really dispute, which is in that it is impossible to isolate and create separate systems in the public and private spheres, right? They will interact no matter what. If nothing else, they're competing for the same inputs to produce their services. They're competing for some of the same pool of patients. And the regulatory regime we use can have a big influence on the extent and the nature of those interactions. We see that from systems around the world. But in fact, you occasionally do hear people say, well, we'll just hive it off and keep it separate. And it's just not possible. The second point I guess I would make, and others have emphasized this already, which is why would people buy a voluntary parallel private insurance policy? And we know it's because there's something missing in the public system that they feel they can buy and they're willing to pay for through a private insurance contract or a private pay. And the reasons for that, of course, vary. We saw some of the data this morning from Ireland. A critical reason in many systems, of course, is shorter wait times, being able to jump queues, greater choice of provider, et cetera. And as others have emphasized, one of, in some sense, the surest way or the best way to try and limit the size and scope and potential for that market is to continually work to improve the public system. Because if people are satisfied and they can get what they feel they need, then, of course, they will be less interested in purchasing such insurance. When we think about who buys it, again, this is a point where the evidence is completely very clear across any system in the world virtually, and that is there's this huge, strong correlation between your socioeconomic status and your purchase of such insurance where it's allowed. And that doesn't matter whether we look at income, education, occupation, however we want to measure this. It's very clear that there's a very strong socioeconomic gradient to who owns this type of parallel private insurance. Of course, ability to pay has a big reason for that. Increasingly, however, such insurance is coming through employment contracts, and so it's selecting relatively well off. And of course, there's different values of time, different tastes, lots of reasons. But the empirical fact is we know that it's a relatively well off who are able to take advantage of the option. And this is, I think, going to have some implications when we think about the regulatory regimes that we would want to use if we were to try and regulate a sector such as this. I'll come back to that in a few minutes. Really the last point I want to make about the insurance sector itself is around risk selection. And there's really two things happening here that I think are interesting. One is, again, in almost every system we look at around the world, we heard some of it this morning, the private insurance sector is exerting a lot of effort to gain favorable risk selection. They're designing their insurance policies, the services they offer, the cost-sharing components, the restrictions on who they'll sell to in terms of age, in terms of pre-existing conditions, chronic conditions, right? All sorts of policies to ensure that they're trying to get the healthy, relatively simple cases into their insurance pools and leave the complicated cases to the public system. So on the one hand, we have them exerting a lot of pressure to have favorable selection. At the same time, this is a secondary insurance market that's voluntary. And so there's a huge risk at times of adverse selection where under the right conditions, it's going to be purchased primarily by people who are sick and who need it. And so you have an interesting interplay of selection issues in these markets that one has to think about when you look at issues of regulation. I just want to say a couple words about, because this is, of course, central to the Canby case, and that is when we look at some of the economics of private finance such as this, what are some of the implications for the public system? Again, I actually think on a number of points of this debate, the evidence is reasonably clear. Other aspects, of course, are more contestable, and the evidence is not as clear. The concern is usually about the impact on quality, cost, and access. And the notion being that somehow the parallel private system is going to increase quality. I think the evidence is pretty clear that it doesn't increase quality in the public system, and it's pretty well understood why that doesn't happen. Similarly, I think most of the evidence is pretty clear that at least as a first order effect, it would tend to increase the cost because you're competing for the same physicians, nurses, technicians, aides, and you're bidding up wages, and it's going to, on average, tend to increase the costs. And we see this happening in systems around the world when you look at some of the contracts. I think those are pretty clear. I think the one that's harder is around what's the impact on access. And it's harder for a very good reason. It's complicated. There's no unambiguous kind of a priori answer we can give to say what will be the effect. It's going to depend a lot on a number of things about the nature of the markets, both the insurance markets and the healthcare service markets, as to what the impact will be. And so I guess we can, however, say a few things. One is the really simplistic stories told either by advocates that say, well, this is just going to divert care from the public system and free up capacity, and it will be a wonderful world. And the stories that say it is absolutely unequivocally going to hurt the public system. Both of those are too simple for what the reality is. These are complex markets, and we know that, for instance, on the demand side, we know it's going to increase total demand for care if you introduce or if you have a parallel private system. We know it's going to change the composition of who's seeking care. We know it's going to change where and why and how they will seek care. And all of these things are mixing because, in fact, public and private are not just substitutes, they're also complements in many situations. You have behavioral responses by people in the system. All of this is going into the mix to determine what happens. Similarly, when we look at the supply side, what's the reason why there's this constraint? Is it funding? Is it a real resource constraint? What's happening? When we look at the supply, for instance, of physician labor, they're actually remarkably insensitive to changes in their total labor supply, to changes in their wages, but we do see them shifting in response to differential wages across sectors. And again, we can say certain things about what would be expected, but it's not certain. I'll say when I look at the overall, and the other thing I would say is, of course, it's going to be specific to certain components. I think the overall evidence, and my reading is on balance, I think it's reasonable to say that it would likely harm access to the public system for those who rely on the public system. Obviously, it's going to increase access for those who can gain this insurance and so forth. So then when we think to the regulatory kinds of approaches that we might try and implement if we were to go down the path of parallel private insurance, I think a couple of points I would make. One is that, of course, Canada has historically had a very light hand in regulating the private insurance sector. Our complementary sector, beyond financial regulations, has almost no regulation compared to other countries. When you look around the world, there's a huge challenge to regulate parallel private sectors. No country thinks they have it right. Every country is trying to figure out how to do better what they're doing. So the idea that there's a simple answer for regulating this, I think, is false. I think what I find interesting in this sector is a lot of the kinds of regulatory policies we have thought about very carefully when the private sector is your primary insurer. Standardized benefit packages, community rating, a variety of approaches become more complicated to think about when it's actually a secondary private market that you're thinking about regulating. And so I think some of the ways we think about these can be turned on their head in certain respects. I'll talk about in a minute. And this brings me actually to I think the most important question is, we would have to really spend a lot of time trying to set out what would be the goal of the regulatory regime. What would we be trying to do? Is it to somehow say, I mean, one would be to say, if it's a luxury consumer good to buy this private insurance, it's going to kind of be on its own. There isn't a huge public interest in this beyond trying to perhaps minimize spillovers in the public system. Some countries, of course, have embraced it. We heard this morning. Their regulatory regimes are trying to encourage people to get this insurance. Everything about them is trying to say, go buy this. Would we, at the opposite end, say our regulatory goal is going to be to limit the extent to which people adopt this insurance, and we're going to try and keep the genie in the bottle even after, if the court case went a particular direction? These would lead in very different directions as you think about some of the regulatory regimes. The other question I think is quite interesting is you get into what's the role of equity considerations. We saw this morning in France a bit in the complementary sector, You know, they introduced the cost sharing. The wealthy could buy private insurance to cover the cost sharing. People said, oh, this isn't fair. The wealthy have more access. So now we'll introduce subsidies to private insurance to make sure everybody has access to this voluntary insurance, which is covering the cost sharing that the government introduced in the first place. And so you can get twisted in knots when you start to really think about equity. Would we want to somehow make sure that Canadians have equal access to this insurance if it's going to be there? So I think a lot of really, really intriguing questions we'd have to sort through from a policy perspective. Clearly what we have heard and what we know is that we have to think about regulation in two markets, the insurance market and in the healthcare services market. In the insurance market, we know that already taxes and subsidies can play an important role. Generally, it's been subsidies in most countries, as actually Mark pointed out this morning. And in Canada, we have a quite large subsidy to private insurance. Would we also provide that subsidy to parallel private insurance, what we currently provide to complementary? Unless we explicit, I believe it would come into this policy. I'm intrigued by almost the opposite. What if we thought about taxing the purchase of these policies? A bit like in economics, a Pigouvian approach that says this has negative spillovers to the public plan, so we'll tax it and we'll take the money and we'll help divert it to support the public plan to try and offset some of the negative consequences. I'm not sure anyone's really raised that, but I don't see why we wouldn't want to think about that if one of the goals was to inhibit the size of the sector. When it comes to premium regulation, again, most countries are trying to control the premiums because they're getting expensive and they want to keep it accessible to everybody. It's a political problem when it becomes expensive, Australia and other places. I'm curious, many countries have community rating, again, where the premium is the same for everybody regardless of your risk class. Obviously, that's often, again, normally brought in for an equity concern. We want to make sure people have access to this. Would we want to do that? The flip side of it I find quite interesting is, of course, the problem with community rating is it generates adverse selection because now it's very attractive for people who are ill to buy this insurance policy. And so it might actually, in this case, inhibit some private insurers from offering certain kinds of policies. And so might it have an interesting effect in terms of the nature of the policies and how large the market would grow if we were to impose a community rating scheme. So very different potential effects on different parts of the market. Coverage, what services and so forth. Usually we think about minimum benefit packages. Quebec, of course, initially said we're going to limit very much what you can cover, and that's played a big role in inhibiting the development of that market. And then when we get to issues about age, so many countries, they just don't sell it. If you're over 65, you can't buy a policy. If you have a pre-existing condition, many of these contexts we say we want to prevent that from happening to ensure people have access. Would we say, well, actually, we're not that concerned if some people can't buy this because it's, again, a private consumption good. I'll just very quickly, to wrap up, a couple of issues in the health services market. Of course, the challenge in all these countries is if you allow your public facilities to provide care through the privately financed scheme, and the problem usually is the charges are too low, so you end up subsidizing the private care, and the hospitals give priority to the private patients because it's new revenue for them. So the simplest thing is to just say no, you can't. If we choose not to, I would be very curious to think about a scheme, for instance, where you require that hospitals charge a very high price, but you don't let them keep that. And you only let them keep the costs, and you extract, for the benefit of the system, the difference. That way, they don't have incentive to give the priority to the private patients, and you're ensuring there's no subsidy from the public to the private. The last point really just deals with the provider contracts and related issues. And what's been emphasized, and I think is really important, and what's critical about the Canby suit is these opt-in policies, opt-out policies, the issues around regulating fees are actually just as central to what happens in this sector as is the question of the insurance market. And really, what we see very clearly is what draws physicians into the private sector is the differential fees and the opportunity to earn a higher income to a large degree, not solely. And so it's going to be really important to see what the options are to continue to kind of regulate the fees and the option for the practices, because these have been quite central to the Canadian story in other countries around the world. So I'll stop there. My time is up. Thank you very much.
So rather than questions, we'll go right through all the presentations, if that's okay. Mark?
While I'm waiting for the slides to come up, Colleen, thank you so much for convincing me to come. It's been so nice to reconnect with old friends. Really happy to do it. And of course, to remember, as Steve pointed out, how wonderful spring weather really is here. This is all joint work with Mary Pierre Isabelle, who's at INSEAD with me, and who is an amazing young health economist that I'm going to ship back to Canada very shortly because I think she's needed here. So credit to her. I want to start actually with a couple of votes, just to get a sense of the room. How many of you think that income inequality is a problem in Canada today? That's most. Anybody not think it's a problem? All right, you're very different from my students, I'll tell you that. And how many of you think this has anything to do with the way the healthcare system works? Fewer. Okay, so that's my job for today, is to show you why I think these two things are connected. And I want to make three main points. The first is that, in fact, income inequality is different from income, and we have to think about it differently from income. I'll say a bit about that. The second is there appears to be, in work that Mary Pierre and I are doing, a relationship between income inequality and the demand for private health services and insurance in Canada. And the third is that there also appears to be a relationship between income inequality and the supply of private medicine in Canada, and I'll show you some new evidence that we just have been compiling on that. Okay, so here we go. You've probably seen a picture like this somewhere before. This is the share of income that the top 1% in Canada has over time. You can see how after many years of being quite low through the 50s, 60s, and 70s, it has risen substantially. Dipped back down during the financial crisis, but it's on the way back up over the last couple of decades. All right? It's not so different from other countries. This shows you the ratio of the top 1% to the median income in a number of other countries, not France, but most countries have been having this increase in income inequality, concentration of income at the top that I want to talk to today. So why is this important for a conference on healthcare? The thinking here that we're trying to push is that, in fact, the more income inequality we have, it starts to undermine the support for public programs because it becomes increasingly difficult to fund public programs that satisfies a more unequal population. Right? You try to hit a program that appeals to most. As one part of the distribution starts to pull away, it becomes harder and harder to do that. What happens? We see adjustments with people demanding more private care, and we see market adjustments to provide that care, and the result potentially is an unraveling of a publicly financed healthcare system. If you think better in pictures than words, this is what I mean in pictures. So we have a increase, the right tail of the income distribution starts to pull away, and as a result, anything that tries to satisfy the bulk of that distribution leaves out the top, and the top seeks something else to replace it. That's what we think might be going on. Okay, so last time Colleen dragged me back to Canada, very happily to have her do it, I talked about the demand side of this. And Mary Pierre and I used some data from the Survey of Household Spending to look at what's happening to the way people are spending their money in Canada. And what we found is that both on direct healthcare private costs, which this graph here shows you, and also on insurance, which I'll show you in a second, we've seen a fanning out, where the top of the distribution is now spending relatively more privately, controlling for the extra income they have. Their differences in income have been fanning out in their demand for private health expenditure, and, as this one shows you, also for private insurance. Okay? These are just graphical representations, but we've been diving into this in a variety of different econometric framework. It seems to hold up. It seems to be quite distinct from what you would think of as a normal income effect with people with more income demand more. That's not what I'm saying here. That's true. But what I'm saying is that as the distribution becomes more unequal, they demand even more than they otherwise would. Okay, that's the demand side. Today, I want to talk a little more about the supply side, and to give her credit, Mary-Pierre has really been doing a tremendous amount of data collection to try and do this. We've collected income inequality data from census tracts. Well, StatsCan gave us income inequality data at the census tract and census metropolitan area from the T1 family files. What we've done with this is we've connected it with private clinic information across the country using both a variety of different websites and ministry sources by census tract. We have a count of 587 of these types of clinics. And we have looked specifically at Quebec, where we have physicians who've opted out of the public system altogether. And we've put them in the census tract that they belong in, and we have 306 of them. And we're looking at the relationship then between what's happening to inequality and what's going on with these clinics and docs. Okay? Just to give you some background on what the inequality I'm thinking about. So the income threshold, most of this work is defined based on the income threshold for the top 1%. So in Canada, to cross into the 1%, you need to have an income of $273,000 on average. This census tract where we're standing right now, you need to have $256,000. The most unequal, not the most unequal, the one with the highest cutoff in Canada has a cutoff of $6,500,000. I won't tell you where it is, but I will tell you, since I've mapped it, that the president of the University of Toronto's house is in it. So I don't know what that says, but I'll leave it to you. Okay, and then we look at the ratio of the top 1% to the median income, right? How many times higher is that 1% threshold to the median? And in Canada, on average, it's 7.5 times higher, all right, which is quite a reasonably large number. But to put it in context, in this census tract we're sitting in, it's 4.5, so a little bit less unequal. And then I asked StatsCan if they give me the ratio of my colleagues' income, Jerry to Ake's. They wrote back quite politely saying, "What do you think we are, Facebook?" So, so I do not have that to show you. Okay, a few maps. This is Vancouver. If you can't read the writing, maybe you recognize. Just so you can see the detail of what a census tract looks like. These are census tracts in Vancouver. And that we superimposed on this is the intensity of private clinics. These are private clinics in Vancouver. And this is what it looks like in Toronto. All right, so the intensity of private clinics in Toronto. And then one more, which moves from clinics to doctors in Montreal. These are by the census tract in Montreal, where the doctors who have opted out of the system are. We have it for all of Quebec, but that's too much to stick on a slide this small. Okay, so I can't get away from these things, so I'm going to show you some tables anyways. You don't really have to look very hard at them. I'll tell you what they say. But what I'm looking at here then is the relationship between this local level of inequality and the probability that we end up with private clinics in that census tract. And controlling for income, controlling for a number of other characteristics of the census tract. And across the board, I've showed you 3 specifications here, but the point I want to make is that across the board, there appears to be actually a reasonably strong positive relationship between these two. All right? The more unequal the census tract, right, the bigger that ratio, the more likely you are to have a private clinic there. Okay? How do you make sense of these numbers? It took me a while, but basically what they're telling us is that really for a shift from the gap from where the median is to the top 1%, that shift in inequality increases the probability that you have a private clinic in that census tract by about 3.5 percentage points, or by 56%, which is a reasonably large number, I think. Okay, so the problem with clinics is that it's hard to know exactly what they're doing. They advertise themselves as doing a mixture of things, some things that are not covered by public insurance, some things presumably that are covered by public insurance, but they're also doing them privately, and it's hard to get exactly at how much of each is going on so far, even though we have quite a bit of interesting data. So what we did is we went specifically to Quebec, where these people we know. have opted out. They are not billing RAMQ anymore for their services. They are providing services that RAMQ would otherwise pay for if they had not opted out. And Quebec is one of the provinces. Danielle pointed out last night that there are some provinces where you can bill more. Quebec is one of those provinces, so they're not stuck with the tariffs that are in the public system, as far as I understand it. And again, what we see here, just to summarize what these charts, which I'll never get away from, I guess, tell us, is that, again, a really strong positive relationship between the level of inequality in the census tract in Quebec and the probability that you have physicians who are opting out. And that is robust. It's not just a Montreal effect. You can look at it directly in Montreal. You might think, oh, this is happening in Montreal, but not elsewhere. Not true. It's happening outside of Montreal as well. And it's happening by any physician type. It's happening by family physicians. It's happening by specialist physicians as well. The magnitude, basically, if you were to think about the moving in terms of the level of inequality from what the median is to what the top 1% is, it actually increases the probability of having a private doctor, and by private I mean outside of RAMQ, controlling for income by 160%. So it's, I'm not going to claim that that's a causal relationship, but it's a big number if there's anything going on here. Okay, so let me recap what this says, and then I'll just speculate a little bit. So basically, I want to point out, it comes through clearly in the tables, maybe I didn't say it clearly enough, but in fact, growing income inequality is quite different from growing income. I'm not talking about people getting richer. I'm talking about the top of the distribution pulling away from the rest. All right? There appears to be a relationship, trying to understand it better, between this income inequality and the demand for private care in Canada. Actually, the relationship is also there across the OECD if you use aggregate data at that level, but I'm focusing today specifically on Canada. And there appears to be a relationship between income inequality and the supply of private medicine in Canada, where we have areas with more inequality. We're seeing more and more private medicine to support the top of the income distribution. That's the end of what the evidence says. Let me try to connect this with the conversation that's going on. I really do support the theory that was put out last night that the best way to fix what's going on with demand for private insurance in Canada is to make the public system better. That's hugely important. But I want to say that this is not just, and the more I look at this, the more I'm convinced of this, this is not just a matter of fixing the health care system alone. That we are seeing large increases, or we've seen large increases in inequality. It is increasingly difficult to have social cohesion around social programs when you have a distribution of people who are so different from each other. And this alone, even if we had a super well-functioning public system, is enough, I think, to start to undermine not just healthcare, but public education, public universities, so on and so forth. And so as we think about this problem, I understand this group is particularly concerned with fixing the public healthcare system, but to my mind, we also have to tackle the bigger social issue, which is, do we have a system in general that is equitable enough, that is fair enough, where prosperity is shared enough that people want to be part of these well-functioning public institutions? And I'll stop there. Thank you.
Thank you, Mark. Okay, will you speak now?
I'll get the slide. There we go. Okay. Good afternoon, everybody. I haven't reviewed the literature systematically or done empirical work. I'm just the old guy that's supposed to provide a little bit of philosophical perspective. So I will try to do that here. The basic subject or issue that I'm concerned with in this presentation is partly why private healthcare finance is such a controversial issue. I'm genuinely puzzled by that, because I think that in terms of what you see on the pro and con side of private finance, there aren't all that much difference in terms of the objectives that people have for the healthcare system, but the differences in terms of support for private finance, of course, are very large. And I ascribe in part the very sharp distinction here and tends to be between economists, not every economist, but many economists on the one hand, and people who are health policy analysts with a more ethically based approach than others. I think that in part the sharp conflict there arises from very different idealized views of public and private finance versus the real world. And I'm going to talk a little bit about what those views might be. I then, let's see if I can get there we go. The idealized views, of course, don't correspond to what we see in the real world. In the real world, everybody has a mixed system with some degree of private and public financing. But in an international comparison, Canada's model is a bit unique, so I'm going to talk a little bit about that. And finally, make a little bit of comments on the possibility of more public-private competition in case what Jeff refers to as the favorable outcome doesn't occur, and instead we do have the unfavorable outcome where the courts strike down some of the regulations that we currently have that hinder the use of private insurance and finance. Now, part of the reason for the controversy between the stylized economist that I'm thinking of on one side and health policy analysts on the other side has to do with the fact that, like all economic issues, healthcare has both an efficiency and equity dimension, and people might actually put differential weights on the equity and the efficiency objectives. I did notice in one of the presentations yesterday that the statements about the objectives of the system that are ascribed to Emmett Hall actually do mention efficiency, but it comes as an afterthought at the very end. Economists, on the other hand, do tend to focus on efficiency a lot more. But it is, of course, not true that economists are not concerned with equity. Mark is not alone in talking about equity in the distribution of income as a whole. Where economists and health policy analysts probably differ to some extent is in how they define equity. Much of the audience here, judging from the presentations yesterday, are concerned with equity about the distribution of one particular service, namely healthcare in the system, whereas economists generally are more concerned with the distribution of real income as a whole. And the distinction between those two are somewhat important, or is somewhat important in terms of understanding where people who actually would welcome an increased amount of public-private competition are coming from. Now, the last bullet point here does make a reference to something that concerns me a great deal, which is that the debate about public-private finance in the Canadian setting, to a very large extent, features contributions by people who have a self-interest in pushing for the alternative that they support. And I think it would be a good thing if in the debate we were a little bit more willing to assume that not everybody on the other side is a person who is making points that are in their economic self-interest. There is a lot of talk about the self-interest of doctors who want to go to private clinics, and a lot of discussion about the self-interest of the insurance industry. But on the other side, there are concerns about the idea that the support for our single-payer system to some extent reflects the fact that many providers today are doing reasonably well in that system and would rather not see changes in terms of increased competition. Now, having said that, let me come then to the two idealized pictures of well-functioning healthcare systems that I identify with the two sides in this debate. They are idealized theoretical models which may be helpful, but occasionally they land you in trouble. There is a saying that in academia, there is no tragedy as great as a beautiful theory that is killed by a fact. And I have actually looked up where that quote comes from. It comes from a 19th century English biologist who was working with Darwin. And the quip is a paraphrase of what he said on that slide. Now, in the sciences, there is much more of an opportunity for beautiful theories to be killed when they are wrong, because the evidence can be made very clear-cut. In the sciences, they use controlled experiments. In the social sciences, we don't do that. And so the evidence, the facts are often ambiguous. Some beautiful theories don't get killed, and it's partly for that reason that we continue to debate, even though we do appeal to the evidence to a large extent, as everybody else does these days. We still continue to debate as to what the evidence means. Now, the two beautiful models that I referred to here is the first bullet point will be familiar from yesterday's presentation. Healthcare should be provided on the basis of need, not ability to pay. It should be financed by taxes that reflect ability to pay. Now, the original slide I had was slightly more provocative, because those of you who have studied comparative economic systems will recognize that this is just a specialized version of something that Karl Marx once said, which is that the economy should be organized on the basis of from each according to his ability, to each according to his need. And even though that model of organizing economic activity in general has not worked out very well in the places where it has been tried, there obviously is a certain amount of appeal and beauty to the idea that we should at least strive for that principle in healthcare, even if we can't use it in general. Now, the second bullet point here is what I regard as the standard economist's view of the role of private finance, and that is based on a model of the world in which we think it's a good idea to let economic resources be allocated by supply and demand in competitive markets, and then achieve equity, if we are concerned with equity, by transferring cash in general, letting people buy with the income that they have, whatever they like, including health. Now, I would argue, as a person who has been an economist for a very long time, that there is some degree of beauty and appeal in that principle as well. The idea that we should organize society and economic transactions on the basis of voluntary transactions between mutually willing buyers and sellers. And so if we can make it work, that would be that we would have a society that would have a certain amount of structure and elegance to it as well. But and you also realize that that second bullet point would then be incompatible in principle with equality in healthcare, because if people are different, or even if income has been redistributed in an equitable fashion, they might buy different amounts of healthcare, buy different kinds of health insurance. And you should realize that the idea that the competitive markets could do a good job in allocating resources must then include insurance markets as well, because the healthcare system does not just depend on or consist of the delivery of healthcare services and drugs. It also depends on the existence of a well-functioning insurance system. Now, both of the two idealized models, of course, are unrealistic. We know about market failure, or you can only need talk about market failure in health insurance. So people have talked about the adverse selection problem, the risk selection problem, and the like. And on top of that, there are the market failures that result from imperfectly informed patients in transactions with healthcare providers. So the extent of market failure in healthcare is very well documented and well known. Government failure, on the other hand, to my mind, arises for a number of reasons. One is that the principle of need, which underlies the first idealized picture, is a little bit hard to define. Who decides what is needed? Or are you willing to let need be defined by healthcare professionals? If you do that, how do you prevent the professionals who define need from defining it in such a way that it serves their economic self-interest? So in that sense, because the potential for government failure as well as market failure, the result is that every real-world system is a compromise with a public-private mix. Now, Canada does have a public-private mix in healthcare financing. The government only pays about 70% of healthcare costs in Canada, which is probably on the low side. I think it's close to the OECD average, but in terms of many of our peer countries, the United Kingdom, France, and depending on how you define things, Holland, we actually have a smaller public share than many other countries. But what is unique about our system are the restrictions on private medicine and private parallel insurance. No other high-income country, no other peer country in the statistics have these kinds of restrictions. Why did we end up being so different? Well, my argument would be that to a large extent it's because the restrictions, when they were imposed during the formative period of Medicare, they were probably necessary, because at that time there was the risk that not enough doctors would switch to the Medicare system, the publicly funded Medicare system, and not enough patients would take advantage of it. So restrictions were probably justified at that time. That's the history part. The geography part relates to the fact that we always compare ourselves in the healthcare debate until we organize a conference like this. We only compare ourselves only with the United States. And any proposal in the Canadian setting for expanding the degree of private-public competition, or even introducing incentive structures in the public system that bear a resemblance to those that have been introduced in other countries with mixed private-public systems, are always represented as the first step on the slippery slope towards an American-style healthcare system. And as a result, we do have a pretty stunted debate, or have had historically a pretty stunted debate about healthcare and how we can draw lessons from countries other than the United States. Now, I then would like to say a few words of what I consider the drawbacks of a single-payer system. The idea that it diverts political energy turns out to be not too dissimilar to the notion that Mark ended his presentation with, which is that even though we have accomplished what we think is a high degree of equity in the way our healthcare system functions, except for the gaps in pharmaceuticals, dental insurance, and the like, it has come at a high financial and political cost. And there is, to some extent, that the cost may simply have consisted in the fact that we are not spending very generous amounts on other social programs that also help the poor. So in that sense, the question that I would like to see discussed a little bit more than it is, is the question of whether allowing a little bit more room for private medicine and private financing of medicine might actually move us more in the direction that many classical economists would like to see, namely more reliance on redistributive instruments such as a negative income tax. Many economists who are concerned with inequality are proponents of the negative income tax and shifting the policy attention in that manner may be one way of accomplishing that. Okay. The final bullet point here that I will have time to say something about is the idea that the lack of innovation in Canadian healthcare, which was the focus of the recent Naylor report that received a fair amount of publicity, may to some extent be related to the fact that we don't have any degree of public-private competition. When providers in the Canadian healthcare system don't like certain kinds of innovation that is being proposed inside the public system, they are able to block it, because in our system that Caroline has referred to as a duopoly between the provincial governments and the organizations representing the providers can effectively have veto power with respect to major reforms. If there was a private sector where various kinds of innovations of an organizational kind, for example, could be tried out, would we get more innovation in the Canadian system than we currently have? That's all I have time for. Thank you.
So now we have an opportunity for your questions and comments. I thought this was a wide-ranging and excellent description of some of the pros and cons, some of the economic and some of the political aspects as it relates to introducing public and private financing in our healthcare system. So let me turn to the mics, and we'll ask our first question. Michael.
Hi, thank you. Mike Rackless at the mic. I'm sorry, Dr. Blomqvist, I have to rise to your bait and ask you, if we did not have a single-payer system for hospital and physician services in Canada, would you lay your money on Canada developing European-style social programs with European levels of spending, or would you lay your money on American-style social programs with American levels of spending on them? I'm going to take 3-1, and I'll bet on Canada developing American-style social programs with American spending. Do you want to take those odds?
I'm an economist, Dr. Rackless, and not a political scientist, so I don't think I would be willing to make a bet on that. But isn't it true that in Canada there is still a remaining influence of our roots or connections with the United Kingdom? And the United Kingdom has moved from a creaky, publicly funded system that sent doctors fleeing from it and coming to Canada into a healthcare system that now, after numerous reforms and some degree of public-private competition, actually functions pretty well. I would have thought that there are enough people who are concerned about preserving our uniqueness in terms of being more equitable than the United States, so that if we scrap the legislative protections, as they are referred to, of Medicare, the kind of reforms that we could see might well end up being closer to the British system.
I'm afraid you can't win my bet by not answering my question.
Right.
My question wasn't about the healthcare system at all.
Right.
Rather, it's questioning the assertion on one of your slides that Medicare is not necessarily good for economic equity, that if we weren't spending money on our single-payer healthcare system, that somehow we would have the child care programs and other social programs that would really benefit the poor. That's what I'm challenging. And I would say that, in fact, if we had that sea change in public values where we erode our publicly financed single-payer system. Right. My sense is that, as maybe Dr. Stabile would add, that it would, by decreasing social solidarity, I think we would make it a lot easier to actually go towards American levels of economic inequality with American levels of social spending. Yeah. That's my question. It had nothing to do with the health system, rather questioning that your assertion that Medicare is somehow in the way of more generous social programs for the poor.
It's a hypothesis that I'm advancing for discussion, Dr. Reckless. It's not an allegation.
Mark, did you want to, or Mark or Jerry, did you want to comment?
At my peril. You know, in fairness, so very briefly, one thing that Medicare does not do particularly well is focus on particularly needy populations, and there. I don't think the solution is to give up on single-payer healthcare, but some attention to 2 points. One, that particularly needy populations tend to be underserved for a variety of reasons, and two, because more needy populations tend to die a little earlier, unfortunately, and some of these public systems are back-ended in terms of, you know, the longer you live, the more you benefit from them. There are some places where we could, without abandoning it, think a little more carefully about how effectively we redistribute, even within a single payer. I'm not taking the odds, but I think there are ways that it could be better to help the needy than it is.
Jerry, do you want to weigh in? A wise decision.
Just
okay.
An observation on the elasticity or the relationship between spending on healthcare and spending on other social services, other social areas of spending in Canada. This is not my question, by the way, but just prompted by the current debate. Canada is very unusual in the privileging of healthcare within the social sector. And when we did, in the 90s, in the interest of deficit reduction, dramatically reduce social spending, including healthcare spending, we then reinvested in healthcare in the early 2000s. We did not reinvest in social spending. We're one of the very few OECD countries in which social spending, other than healthcare, as a proportion of overall government expenditure, let alone GDP, actually declined in that decade between 93 and 2005, 95 and 2005. So, you know, what the counterfactual is, if we hadn't invested in healthcare, would we have invested more in other areas of social services and social spending? I don't know. But what is clear is that we've privileged expenditure on healthcare. Now, for my question, which is totally unrelated to that, and it's for Mark, really an arresting presentation and an aspect of income inequality that certainly I hadn't given sufficient attention to. But I wonder, you do break out metropolitan areas in your presentation. I was trying to follow quite quickly along with the slides. Is this in fact a metropolitan phenomenon? The coefficients, as I was scanning them, are very similar in your overall sample and in your metropolitan sample. And is this reflecting the fact that income inequality is higher in metropolitan areas? Private clinics tend to be located in metropolitan areas, not only because of the greater demand from the 1%, but because of the lifestyle of the providers themselves. If it is a metropolitan phenomenon, it's still equally worrisome. In fact, potentially even more worrisome in that it would play into the overall politics of the urban-rural divide. But have you explored the extent to which it really is a metropolitan phenomenon?
Yes, I have explored it. It's impossible to, because of exactly what you've said, right? It's impossible to do this kind of work if we were to leave out the big cities, because a lot of the action happens at the big city level. That said, it's not just a big city thing. it is true that if we try to just level out a Montreal, Toronto, or Vancouver effect, the results still hold. And I went too quickly for you to see that, but that's on purpose. It's a protection mechanism. But it's there. But also it holds if you just use the big cities, right? Whereas if you just ignore the big cities, it would not hold. So in part it is. The extremes, up and down, are all in and around the big cities, right? Yeah, it is. There is an urban-rural thing happening here. I don't think we'll see a flourishing of private clinics in rural areas, right? That's so it is mostly happening in big cities, but it cannot just be explained by saying we're going to net out the Montreal thing here or the Toronto thing here. It does hold.
Mark, could I just add parenthetically that as a provider, if you have to have a critical mass of people who have the wealth and demand the 1%.
That's right.
So you can't be in a smaller town when there's only 3 people in that 1%, and then you're going to devote yourself exclusively to the private sector. So I think there's a pragmatic aspect. You just have to have enough people in the 1%.
Yeah, I think that's right.
Sorry, just to follow on that, this does really matter for reasons beyond the healthcare sector, and I think that's what I wanted to emphasize as well, that this plays then into the broader politics of the urban-rural divide. And we see it not just in Canada. We see private clinics in London are dramatically more private sector usage in London than elsewhere in the UK. And it plays into the kind of privilege versus resentment politics of the urban-rural divide that I think are very destabilizing for liberal democracies. So Mark's findings have implications far beyond the healthcare sector, I think.
Let's go to our next question. Good.
So thanks very much. Great panel. The whole day is like a crash course, so by the end we're all ready to continue as baby economists or whatever. And I take the point about beautiful theories. That's a terrible flaw of mine. And I guess given how poorly the Trudeau government handled the very tiny, modest little tax changes that they were proposing, that would suggest what I'm about to ask is a beautiful theory. But could one achieve most of the objectives one wanted in terms of controlling privatization through the tax system and just completely leave the healthcare system aside and just do it all through getting rid of hidden tax spending and actually taxing?
Who wants to jump that? Jerry?
Sure. I mean, I think it would have an effect and it would limit. Would it get rid of it altogether? No, I don't think so. Because there's more to it than just the fact that we currently do subsidize the private insurance sector. But could tax policy, I guess that's why I raised the issue of even thinking about not just getting rid of the subsidies, but would we think about a positive tax, just like a carbon tax? We want people to consume less carbon, so we'll put on a carbon tax. And use the resources to help environmental policy. In this case, it's just let's put a tax on private insurance of that type. So I think tax policy has the potential role in achieving the kinds of social and health goals we have for our system. Again, I would just come back to, I think we have to have a much bigger conversation about what do we want to achieve through our regulatory policies in this kind of a world, because and that's why this conference is so important. In some sense, so much energy has gone into just saying we can't let it happen, to now, okay, if it's allowed, what do we do? And we just haven't thought enough about that. And I don't think the answer is automatically we have to do everything possible to squash it and make sure it doesn't arise. I think we have to think more in a more nuanced way about what our policy goals should be as we think about regulating the sector.
Mark, did you want to comment?
Yeah, I would be a little stronger maybe than Jerry on this. I'm super supportive of the idea of It gets us out of the ethics issue, actually, to think about private insurance as a negative externality and therefore to tax it, because we know it harms the public system. I would venture, without taking anything away from the issues you're raising, I would venture that a combination of getting rid of the subsidy, which effectively doubles for many people the cost of private insurance, and adding a tax to think about the negative externality would more or less kill the market for most people. I mean, that's doesn't take away from other things that have to be done, but I actually think, I mean, I love taxes, so that's, at least I love tax policy. Anyways, so I would be more positive that we could go a long way that way.
I mean, obviously depends how big the tax.
Yeah, that's right. That's
Okay, do you want to get in there?
For the record, I also favor abolishing the tax subsidy that exists on current private insurance. I probably wouldn't go as far as to tax it because I'm not as convinced as Jerry of the reliability of the evidence that suggests that a parallel private system hurts the public system. I thought I interpreted what was said about Australia as saying that part of the reason private insurance is struggling there is that people are satisfied with the public system. The question that one may raise, if one comes from my vantage point, is are the improvements in the public system in part a response to the threat of competition from the private insurance or private practice?
Okay, thank you. Let's go to our next question.
Okay, I have just two pieces that were raised by a couple of the panelists there. The issue on the rising inequality and its impact on the private insurance. Was there any mind to what role austerity had in that same period, i.e. like since 2008 in the financial crisis, we've seen governments imposing austerity in the public sector frequently, and they've restricted spending and growth in areas such as healthcare. And was there a role in the increase in private healthcare being demanded by those who had the money to pay for it? What role did that have to play in it? And also the issue in whether single payer or private public payer system is more efficient or not, or the costs, and which market should decide. We have multiple examples of, where private insurance actually costs more, and I'm going to highlight the Saskatchewan example of MRIs, what we have in Canada. In 2016, the Saskatchewan government decided that they were going to allow private clinics to charge a fee for MRIs. And that fee was allowed under the premise that they were supposed to deliver for every private scan, they were supposed to deliver one for a public wait list. And what they found out when they actually asked how much the costs were for those scans, they found out that it was costing $900 to $950. That was the base rate for that MRI scan. And then when they actually measured what people were paying across Canada for under the public system in hospitals in Ontario, for example, the scans were $300 or less. So I'm just wondering how we measure a public and private system if we don't bring in the actual costs on what the system is paying when they're charging more in a private system. Like, how do you discuss efficiencies and which model is better if you don't bring those into the equation?
Everybody's pointing in the chat.
Yeah, I mean, I guess obviously, in some sense, what you get into is a question of if we choose to obtain some services from private providers, and again, I really think it's important to separate the question of private finance from private delivery, right? In some cases, we may choose to use private providers. I mean, obviously, most physicians are private providers, but private clinics or whatever. Then you're down to a range of issues around contracting. And can you write a good contract, and can you enforce that contract, and can you do it for the right price? And to a degree, the question then becomes, we need a new set of skills in the public system to be able to do that well. And we know, I mean, it isn't hard to look across the public sector to know we very often do a very bad job of that. And every day there's stories in the newspaper about crazy contracts that were done in the private sector, ripped off the public sector because we didn't contract well. And so it is an issue we, of course, would have to look at very carefully. We also have to think about, in some cases, where the costs are lower. Why? Is it actually more efficient? Is it just a selection effect happening where they're servicing a particular type of the population? And so, in fact, for that subset of the population, it isn't any more expensive than the public anyway. There's lots of issues involved here. But the question of trying to ensure that if you do try to go the route of private contracting, even with your public dollars, the issue of cost and trying to ensure you're getting a good value for your dollar is obviously a critical part of that. I also think it's, just to go a little bit off that, or extend a bit, you know, to talk about competition between public and private, again, I think we have to be very careful. Having a parallel private finance system, I think there's really almost no evidence that would suggest it generates competition with the public system. They're serving different people. The public system's overwhelmed. It's not like they're worried about losing patients and, oh, we better respond because this private clinic servicing these wealthy people is taking away our needy patients. That's why I don't think it's going to induce the kind of competition that would benefit the public system. I think that's a different question than, is there any role for the use of competitive forces in areas like contracting with your public dollars to use a variety of providers in various ways? And I think that's where the UK doesn't use competition from the parallel private sector. It simply redesigned the public system to use competitive forces even amongst just purely public providers. And that's where they got the benefit. So I just think we need to be very careful about making assertions about public-private competition and then thinking about the private finance side, because they're very different. They're different issues. Sorry.
Okay, do you want to remark?
Then very quickly on the austerity. So it turns out, it's not strange, but it's unfortunate that crises are good for inequality, right? So the Depression, the wars, the financial crisis all reduced inequality. And the last financial crisis actually did, if I remember the data, there was a publication on this, did increase out-of-pocket spending for just about everybody. So you're right that there was an effect of austerity and the crisis on out-of-pocket spending, but it reduced the gap because, not in a good way necessarily, but because other people started to spend more privately. In fact, the differences between them and the very top got a bit smaller. So it's a bit weird, but austerity is part of the story, usually by forcing the rest of the distribution to spend more out of pocket.
Okay, you're okay? Yeah. So let's go to our last question.
Okay, thank you. Thank you for the panel for this very illuminating and mind-provoking presentations. First, I have to admit that as an economist, I am completely obsessed by efficiency. And I actually would say that efficiency is an ethical obligation and to use public resources correctly. So with this in mind, I have two questions related to two ideal models that you put down. The first one is about the ideal of providing equal access by need, not by ability to pay. First, I would like to say that we need this ideal. This relates to Jeremy's point that he made several times. What are we looking for? If we don't have this ideal, and if we don't defend this ideal, I think there's no point being health economists, because this is what we are working for. If we don't have this, then you let it go. We don't care about the inequalities. So, but clearly, the definition of need varies across countries. In Canada, you have a very narrow definition of need, the basket. We have a very large definition in France. So my question to the panel is, do you think that definition of need has an impact on the efficiency of the public system? And my second question is about the second ideal, the market's failures. We know, like the intervention, public intervention in health sector is a necessity, it's a technical obligation because we know that markets are inefficient. So there are information asymmetries, induced demand, etc. So we know that they're inefficient. So do you think in a single payer system, letting public-private competition without regulation can improve efficiency?
Yeah, start, please.
I do think that an ideal of need does have a very major role to play. My ideal system is a system where everybody in society has access to public health insurance as an option, but they should have the right to opt out if they prefer a different model, different private insurance. And politically, a well-articulated concept of need or a set of rules for how you measure need and establish it would be the guiding light for the public insurance plan. That would be the default option that I would favor within the context of a system with the right to opt out and therefore some degree of public-private competition. For those who are interested, I have written about what I regard as the ideal model of pharmacare in the Canadian setting, and I'm shortly going to publish something on dental insurance. In both cases, I argue that it would be a good idea to have a public sector default plan. In dental insurance, we don't yet have that, but that's the model that I would favor. And I also think that the Quebec model of pharmacare, which is based on the idea of a public default option, but with the right of opting out, is not a bad way to go.
Mark?
This is not for you, but for in general, I think it's super important to remind people that efficient doesn't mean less, right? Efficient doesn't mean cheap. Efficient means using resources wisely and the right amount, given what people need, right? And so I think you're absolutely right that the definition of need actually is critical for efficiency, right? The very first paper I wrote in health economics showed that people who didn't have drug insurance were skipping doctor's visits because they knew that the next thing they were going to need was a prescription, which they couldn't afford, so why waste the time going to the doctor, right? Contrarily, people who had lots of drug insurance would go to the doctor more often because the cost of doing so. That's completely inefficient, right? So that definition of need undermines any sort of public efficiency argument, right? And so I think you're absolutely right that the way you define need is going to be critical to maintaining an efficient system.
Ditto. He did. It was exactly the answer I was thinking about. I have to admit, you had a second question. I was partly thinking about your first question, so I'm not sure I heard it completely clearly. But what I did hear is a question about do we think something about public and private competition without regulation? And I guess my quick answer would be I can't see how you could possibly have effective public and private competition without setting a very strong regulatory framework and context in which it has to be structured. Otherwise, and it's the only way you would possibly achieve goals that you would set for your social and health and public policies.
And would that regulatory framework have a cost and it hasn't been considered in an existing single-payer system?
When you say would it have a cost, do you mean in the sense of, I mean, clearly it's going to take resources to develop it. It would require resources to apply the regulations and to ensure that people, so yeah, there like any, yes, there would be costs.
Okay, you made that point earlier. So on behalf of our panel, I'd like to thank you for your questions, and I'd like to thank our panelists for thoughtful and organized work. Will you talk about our next steps, lunch?
Hi, I'm Brian Thomas. I'm with the Center for Health Law. I just wanted to mention that you've got like 15 minutes to grab lunch, and if you could just quickly return to your seats because we're going to start with the next panel. Thanks.